Good morning, everyone. My topic for the day is endodontic emergencies. So, in this, I will be covering in detail about what exactly is endodontic emergencies, the basic classification for it, then the diagnosis of emergencies and how do we treat it, and the pharmacological support that we attain in order to manage this. Okay, so now moving on to the definition, what exactly is endodontic emergencies? We know that in a dental clinic or a dental hospital, 80% of the patients that walks in us request an endodontic treatment or a restorative treatment. Now, endodontic emergencies are most prevalent. Now, if you have a survey, it is mainly mentioned that around 60% of the people in emergencies are dealing with endodontic emergencies. Now, endodontic emergencies are circumstances that are primarily associated with a pain or swelling that require an immediate diagnosis and treatment. That is, a patient walks into something like an unscheduled appointment. As a circumstances that the patient just walks in with an aggressive pain or an associated with pain or swelling that may always require an immediate diagnosis and treatment. Now, according to Watson and Ford in 1992, it is the occurrence of severe pain or swelling that is following an endodontic treatment appointment requiring an unscheduled visit and active treatment. Now, according to Grossman, it can be classified as acute conditions, that is the reversible pulpitis, the irreversible pulpitis, the alveolar abscess, and the periodontal abscess. Now, it is also that emergency during the treatment. That is normally it is something like we can classify based on how it has happened. That is, there are some acute conditions. For example, there are the reversible pulpitis, irreversible pulpitis, the alveolar abscess, and the periodontal abscess. And there is something called as an emergency that arises during our treatment. Now, there is something called as fractures that can be either crown fractures or root fractures. Then we have something called as an avulsion, a condition where the tooth has come out of the socket. Then we have something called as a referred pain. Now, according to Walton, it is based on the appointments. That is based on the schedule of treatment. That is, there is a pre-treatment emergencies, there is an intra-appointment emergencies, and there is something called as a post-observation emergencies. That is something that is initial or prior to any treatment that we do. That patient comes up with a swelling or something. Now, the other is inter-appointment. That is one sitting we do an access offering, then we send the patient back. Then patient has some endodontic flare-up, where patient complains of severe swelling and pain. That is something called as an intra-appointment emergency. Then there is something called as a post-observation emergency. That is, you finish up the single sitting endodontic treatment and you end up with a swelling after post-observation. So, according to Walden, it does have pre-treatment emergencies, intra-appointment emergencies, and post-observation emergencies. Now, moving according to Goodman, it is the treatment of the vital pulp. That is, it does have acute irreversible pulpitis, and we have something called as hypersensitive dengue, the recurrent decay, the recent restorations, and crack tissue. Whereas there is treatment of non-vital pulp includes acute apical periodontitis, necrotic pulp, the acute alveolar abscess, the phoenix abscess, and acute irreversible pulpitis. Now, there is aesthetic emergencies, that is the fracture of crown, fracture of tooth, and pebbles. According to Wayne, there is an initial therapy for a thorn tooth. There is an emergency treatment of traumatic injuries, that is a fractured tooth. Then there is an emergency treatment of traumatic injuries, that is the Evers tooth. Then there is an emergency treatment of intra-appointment. Now, how do you really manage an emergency? Normally, we know that it is not. There are certain ways to manage an emergency, and the prior thing is the proper attitude. Because if a patient walks into your clinic, if a patient walks into a department with an aggressive pain swelling, it is always mandatory that you attend the patient with a proper attitude. You console the patient, make the patient confident that yes, this can be cured, and this is something that is inevitable. You need to go through this. It is something a proper diagnosis can lead into a proper cure of the situation. So the management mainly as of proper attitude, that provide profound anesthesia, and the 3Ds, that is the diagnosis, the definite treatment, and drugs. So provide profound anesthesia. That is in case of hot tooth. Hot tooth, it is a general condition where a tooth, though it is anesthetized, it is found to have a proper symptomatic condition. That is, you have a pain on 3-6, you give a good anesthesia. Patient tells they are having a numbness on the lower lip, or on the left side of the lip. There is an anesthesia on the tongue, but still you have a severe pain while you are cutting through. into the axis. Then it is something called as a hot tooth. In this tooth, it is always difficult to anesthetize. That is because there is a special class of sodium channels or C fibers, the tetrodotoxin resistance, and it is more resistant to anesthesia. The simple problem is in these cases, the nerve fibers are such a way that it is more resistant to anesthesia, and anesthesia cannot have an aggressive effect on this to have a total anesthetic effect. Then there will be supplementary sites of injection, that is intralegnary and intrapulpate to manage the anesthesia. Now, the diagnosis, it is mainly of subjective information and objective information. It is of a history of pain, the stimulus of pain, the frequency of pain, and the duration of pain, location of pain. The objective information can be the visual examination, where patient will give you certain conditions. Then you have percussion or palpation. You have a sinus tract that can be seen, that will help us to track the where the origin of the disease is. Then we have something called as tooth fractures, the fracture restorations, periodontal disease and mobility. Okay, now there is something secondary or supplementary things that will be helpful for us. That includes we have something called as a radiographic assessment and comparative test. Then this all with all these diagnostic aids, the subjective finding, the objective finding, we need to get into a diagnosis which will give us a proper treatment plan. Pre-treatment emergency. So based on the classification, it is of acute reversible pulpitis, acute irreversible pulpitis, acute apical periodontitis. Then we have pulpal necrosis with periapical abscess, acute periodontal abscess, and traumatic injuries. Now, acute reversible abscess, it is a mild to moderate inflammatory condition of the pulp that is caused by a noxious stimuli. Okay, with pulp is capable of returning to the uninflamed state after removal of the stimuli. So, in simple words, the patient complains of a pain. Then what we do is we do a simple fold test, that is with the help of an eye stick. You keep an eye stick, that is a stimulate, you keep it over the symptomatic tooth, and you see for the reaction. So, a patient would complain of a pain. Then on certain removal of the stimuli, the pain disappears. So that gives an indication that it is of a reversible condition. So here, the pain subsides on the removal of the stimuli. Now, another thing is, there is a condition where this pain is continuing or of a lingering type. That is when you place a stimuli over the tooth, and on the removal of the stimuli tooth, the patient doesn't have a reduction of the pain, and there is something of a lingering nature. That gives you an indication that it is of irreversible nature, which will always require an endodontic therapy. Now, in case of acute reversible pulpitis, the causes may be a trauma or an arterial occlusion, a thermal shock, an excessive dehydration, the galvanic shock, the chemical stimulus, bacteria from caries, the optic vascular congestions, the circulatory disturbances, and it can be of a recent restorations. So diagnosis, it is the patient symptoms, the clinical examinations, the clinical test. Now the treatment will require the recountering the high point in case of occlusion. The use of sedative semen, that is of Zedoid. Patient should we should apply in case of dentin hypersensitivity. We should apply in case of varnish, dentin bonding agent to desensitize the tooth. And in case of prevention, you should have a pulp protective base, avoid marginal leakages, and proper contour of all restorations, and avoid thermal shock. In case of acute reversible pulpitis, it is a persistent inflammatory condition of the pulp, symptom or asymptomatic caused by noxious stimuli. Here there is a bacterial involvement of pulp to the caries, and what happens here is there is a deterioration of reversible pulpitis. The main factors that might be included is of a chemical, thermal, and mechanical nature. Diagnosis is based on the type of pain, the clinical examination, and the radiograph. Here we can see in the radiograph that there is a radiolucency that is involving the enamel and the pulp. You can see the pulp, the basal pulp horn is attached to the caries. So this is of a reversible pulpitis, and we should also look for a clinical condition where patient will have an lingering pain. So that means as a diagnosis of irreversible pulpitis, and treatment plan involved an endodontic therapy. You can see an endodontic access cavity prepared and a maturation be done using the temperature of these cases. In treatment in anterior cetus pulpotomy, the posterior cetus pulpotomy or pulpotomy. So, according to the British Dental Journal 2004, it is a corticosteroid or antibiotic dressing with zinc oxytocin temporal restoration is good in effective short-term dressing for management of irreversible pulpitis. Now, the signs and symptoms. It is mainly in case of reversible pulpitis, the duration of pain is short. The irreversible pulpitis, it lasts for few seconds to hours, and lingers even after the removal of the stimuli. Okay, when we consider the localization of the irreversible pulpitis is simple or it is difficult. And in case of irreversible pulpitis, it may leave at radius initially, and once medial is involved. Responsible to vitality, cold test is mostly preferred. In case of reversible, it is the cold test, cold relief speed, whereas heat test is more significant. In tenderness to percussion, mainly in case of reversible pulpitis, it is absent, whereas in case of irreversible pulpitis, it is present in the later stages. Now, in case of radiographs, if we see it, it is of normal, that is wide and medial is seen in case of reversible pulpitis. Now, what is acute apical periodontitis? That is simple. When a patient have a problem in the periodontal area, that is the periodontia gets inflamed. Periodontitis as there is an inflammation taking place. Now, what is acute apical periodontitis? Simple. The tooth, it is a painful inflammation of the periodontium as a result of trauma, irritation, or infection through root canal, whether the pulp is vital or non-vital. In this condition, it can be that the tooth might be vital or non-vital. What does its main classification? What clinical scenario? It is just tender on percussion. That is, the patient will complain of a tender on percussion. So that will lead into something called as apical periodontitis. In this case, the tooth might be vital or non-vital. Now, causes vital, it might be due to the fudging of foreign objects or any high points, that is any occlusal defects. Now, in case of non-vital, it is mainly due to the sequelae of pulpal diseases. So symptoms may be pain or tenderness of the tooth, and the tooth might be extruded, and the tenderness of the apex of the tooth is the buccal cells. Diagnosis is subjective symptoms, the radiographic findings. Treatment as vital is occlusal adjustment. In case of non-vital tooth, it is a root canal treatment. Now we have something called as an acute alveolar abscess. Acute alveolar abscess is also called as an acute apical perisymatitis, acute radicular abscess. It is a localized collection of pus in the alveolar bone. You can see in this image, there is a local collection of pus in the alveolar bone at the root canals, following the death of the pulp. The extension of the infection through the apical foramen into the periapical tissue. Now there is an aggressive areas, so there is an infection on that is involving the enamel, then to the dentin, then to the pulp, then the coronal pulp is affected. That infection or bacterial spread is invaded deep into the periapical area through the apical foramen. It is having an infiltration into the periapical tissues. So there is always in this case in the acute alveolar abscess, there is a collection of pus into this area. Now it is a localized collection of pus in the alveolar bone at the root apex following the death of the pulp with extension of the infection through the apical foramen into the periapical tissue. So cause is pulpitis, pulpal necrosis, and periapical tissue. Or there may be an exacerbation of the chronic periapical lesion. That is, a chronic apical periodontitis may lead into an acute alveolar abscess. Then there is an endodontic periodontal invasion, that is through the lateral canals and deep infrabony pockets. Now, diagnosis, its symptoms includes tenderness of the teeth, mobility, swelling, symptomatic toxicity, and clinical test. Radiographs may be periapical radiography. So, treatment is nerve block is administered. Nerve block is administered. It stabilizes the tooth with the finger pressure and impression during the axis is made. That is stabilize the tooth with the finger pressure. Once the pulp chamber is opened and polluted discharge is present, it conflicts the instrument within the canal. That is normal in these cases, and immediate access operation is there. And this first is made to get outside, like through the orifice outside the root canal space. So that itself will give an immediate relief. Then followed by a pharmacological therapy. Now, irrigation is always good. So, older concept was leave the tooth open if no drainage was seen, or close the sink was also performed. But if you file, don't close. There's a famous concept that if you file, don't close. If you close, don't file. That is something that is based on the chemomechanical preparation. Then even analgesics and antibiotics is given, and there is what saline uses for 3 minutes. Whichever is also advised much into it. Now I get a periodontal abscess. These are the topics to be covered in the coming sessions.